So acute leukemia is a disease of malignant leukocytes, a disorder of neoplastic leukocytes that are dividing out of control. They are predominantly made up of immature forms, specifically myeloblasts or lymphoblasts. And the disease is defined by greater than 20% of blasts within the bone marrow. The symptoms that are manifest in acute leukemia are often due to leukemic infiltration overcrowding the marrow, causing pancytopenia. So the presenting complaints are often fatigue, pallor, malaise, or easy bruising and bleeding that are manifested in thrombocytopenia. Or recurrent infections also can be manifest, even though there are hundreds of thousands of white cells circulating. None of them are functioning normally. So these patients are also at increased risk for infection. Risk factors for acute leukemia include chromosomal abnormalities, specifically trisomy 21, Down syndrome, ionizing radiation from either occupational exposure or prior therapy for pre-existing malignancy, chemical exposures including chemotherapies or benzenes or some of the other industrial chemicals, and alkylating agents specifically in terms of chemotherapeutic medications have been known to cause acute leukemias down the road. So acute myeloid leukemia is a disease of immature granulocytes from the myeloid line. And these are seen in young adults to middle-aged adults between the ages of 15 and 60. Acute lymphocytic leukemia is a disease of the immature lymphocytes, pre-B and pre-T cell ALLs. And these are typically seen in children. AML is associated with specific cytogenetic abnormalities, such as the translocation of 15 and 17, which is acute promyelocytic leukemia, APL, translocation 821, and 11q23 abnormalities. These genetic abnormalities lead to defects in the maturation of the stem cells and their abilities to produce a clonal expansion of these abnormal leukemic blasts. Oftentimes, acute myeloid leukemia begins as a myelodysplastic syndrome, and it is often thought of as MDS as a pre-leukemic condition. Can present with pancytopenia, with a shift to immaturity in the myeloid lineage. However, it doesn't meet that diagnostic criteria of greater than 20% blasts in the bone marrow. The dysplasia can be trilineage. It can certainly be red cell disordered, thrombocytopenia, as well as leukopenia. It tends to occur in folks who are closer to the age 60 end of that 15 to 60 range. And it's especially common in people who are treated with a prior chemotherapeutic regimen, specifically with alkylating agents. The morphology seen in acute myeloid leukemia is characterized by abnormal myeloid blasts with very large nucleoli with a nuclear to cytoplasmic ratio approaching 1, prominent and densely staining nucleoli, as well as cytoplasmic granules with what is termed an Auer rod, which is a fusion of lysosomal granules that causes bundling and a linear deposition within the cytoplasm of these atypical cells. You can see them bundled in many. In terms of promyelocytic leukemia, you can have multiple Auer rods within the same cell. And these granules will stain with an antibody against myeloperoxidase. So a good look at some of these atypical myeloblasts with Auer rods seen in them. So you see those extranuclear inclusions of an area of linear density just outside of the nucleus. You can see that the cells are very, very large in comparison to the red cells, and also the nuclei take up most of the cytoplasm. So that's that high nuclear to cytoplasmic ratio. The French American British classification of AML basically goes through the different types of cells that can be involved. So M0 is completely undifferentiated. It can be any number of cells in the myeloid lineage. M1 is AML without much in the way of maturation. You know that it's a myeloid cell, but they are all very premature. M2 is there is some degree of maturation of the myeloid lineage. M3 is acute promyelocytic leukemia, abbreviated APL, and there are some specific medications that can be directed against APL. M4 is myelomonocytic, so it is of the monocyte lineage. Same thing with M5, monocytic to monoblastic. M6 is an interesting entity called erythroleukemia, where the erythroid precursors are the ones that are dividing out of control. And in M7, it is megakaryoblast leukemia, so the platelet precursors are the ones dividing out of control. Symptoms of acute myeloid leukemia are, as we mentioned earlier, easy bruising and bleeding from thrombocytopenia, susceptibility to infection from ineffective circulating leukocytes, as well as weakness, pallor, and fatigue from the anemia. Also, you need to consider patients with bony pain, specifically in the pelvis and back, where there is extensive marrow infiltration with these atypical leukemic cells. M3, acute promyelocytic leukemia, is associated with DIC, and the specific therapy used in APL is all-trans retinoic acid, or ATRA. So if you see an M3 leukemia, you can use all-trans retinoic acid as the therapy. Moving on to acute lymphocytic leukemias, there is defective maturation of a lymphocyte precursor. So these are either pre-B or pre-T cell ALLs. And they can be extramedullary or they can be within the bone marrow. You can have a lymphoblastic lymphoma that is outside of the bone marrow but within the lymphoproliferative system. So you can have a lymph node with pre-B or pre-T cell ALL. This malignancy can metastasize to the CNS or to the testes and can cause mass effect issues in ALL and can cause multiple disorders wherever they manifest. ALL is also defined as with AML as greater than 20% lymphoblasts. So these lymphoblasts are smaller than the myeloblasts, and the nuclei are essentially taking up the entire cell. The cytoplasm that is present in ALL is very darkly basophilic, very deeply blue staining. And you can see how the nucleus takes up pretty much the whole cell in those lymphoblasts that you can see out there peripherally. So from a pathology standpoint, we can look and see pre-B versus pre-T cell ALL. And 80% of the time, the ALLs are going to be pre-B cells. And the onset is a little bit earlier. The site is typically in the blood or in the bone marrow. And the white blood cell count can be relatively normal. Prognosis for pre-B cell ALL is relatively good with treatment, but the symptoms between pre-B and pre-T cell are essentially the same, with pancytopenia and bone pain, as well as neurologic symptoms. Pre-T cell has a remarkably different age of onset, as well as a site of involvement. So the mediastinal mass is often the first site of pre-T cell ALL. And the prognosis is much different from that of pre-B. Concluding our discussion of acute leukemias, moving into the chronic leukemias. Chronic, in this sense, does not necessarily mean time course. It just means that the cells themselves are more mature. So they are derived from not necessarily the myeloblasts, but sort of more down the line of differentiation. So you can have similarly to the other discussions that we talked about, you can have CML and CLL, chronic myelogenous or chronic lymphocytic leukemia, a specific subtype of chronic leukemia called hairy cell leukemia, or adult onset T cell leukemia and lymphoma. So CML is defined by the presence of the Philadelphia chromosome, which is a translocation of 922, which fuses the BCR and ABL genes. The ABL gene product is a tyrosine kinase that controls cell growth, and the fusion protein that's generated from the apposition of these two regions leads to uncontrolled growth of maturing myeloid cells because of the unregulated activity of the ABL protein. This is both a schematic as well as a karyotypic manifestation of what the Philadelphia chromosome looks like as you have that T922 translocation. So what does it look like? The morphology basically has leukocytosis with increased immature granulocytes. So you'll have myelocytes, metamyelocytes, and some bands out there in the periphery, as well as an absolute basophilia. So those premature cells that are commonly seen in normal bone marrow are now out in the periphery. You don't see much in the way of circulating blasts, but you do see those immature forms in CML. The average onset age in terms of CML is between the ages of 30s and 50s. The onset itself is slower and more insidious than some of the acute leukemias. The symptoms are much like any of the other leukemias. You have anemia causing weakness and fatigue, and splenomegaly from the splenic involvement of the leukemic process, causing abdominal fullness and some pretty remarkable pain. Early satiety, premature fullness from a meal is also common in the setting of very large splenomegaly. CML can slowly progress over years and become much the same as AML in terms of having a blast crisis, an acute and accelerated phase, as the patient becomes refractory to treatment and having chronic and refractory cytopenias. The chronic phase of CML is treated successfully with Gleevec, or STI-571. It is a tyrosine kinase inhibitor which revolutionized targeted therapies in the treatment of malignant disease. Gleevec-resistant disease is treated with bone marrow transplantation and carries with it, in terms of Gleevec resistance, carries with it a remarkably poor prognosis. Moving on to a discussion of CLL, it is a neoplasm of maturing peripheral lymphocytes. It may present as either isolated lymphoma, small lymphocytic lymphoma, or simply lymphoid leukemia predominant in the bone marrow. Either way, the bone marrow is always involved in CLL. Spleen and liver can also have some manifestations depending upon the degree of leukemic infiltrate. So CLL disrupts normal immune function by hypogammaglobulinemia and increased infections because the lymphoid cells that are circulating are not effective at clearing the bacterial and viral infections. You can also get an autoimmune hemolytic anemia or an idiopathic thrombocytopenic purpura, as the globulins that are being created are against nonspecific entities and can't even be directed against self. Some CLLs can transform to more aggressive forms, just as CML transformed into AML in a blast crisis. You can have a Richter's transformation from CLL to a diffuse large B-cell lymphoma, which we will discuss in the lecture about lymph nodes, spleen, and thymus. The morphology of cells in CLL, they are small monomorphic lymphocytes with a cracked chromatin, and what you can see there is there's a single site of cleavage right down the center of the area of the nucleus. Also, the classic thing that you can see in CLL is a smudge cell. The cells in CLL are more friable than normal, and in the process of obtaining a peripheral smear, as one glass slide is slid across another, the smudge cells can be created from mechanical lysis of those atypical lymphocytes. CLL is usually a disease of patients over the age of 60. The white cell count can range from relatively normal to greater than 100,000. The onset can be relatively insidious: fatigue, weight loss, malaise, anorexia. Lymphadenopathy is often present but is not always seen. The progression is slow, and the median survival can be between 4 to 6 years, but if the disease transforms into a diffuse large B-cell lymphoma, the median survival is less than a year. So differentiating leukemia is based on the age of onset as well as the time course of onset, and the symptoms can be very helpful when determining ALL from AML, or better said, ALL from CLL and AML from CLL. So the acute leukemias, it's easy to think about as more of a disease of the young, and the chronic leukemia is more as a slower disease of the elderly. The prognosis of the acute leukemias is getting better. These leukemias are particularly sensitive to chemotherapeutic agents and can go into remission and develop the ability to perform subsequent bone marrow transplantation because these cells are dividing so quickly. The slower growing, more indolent chronic leukemias are often difficult to treat, except for CML, which is used, when used with Gleevec, actually has a good rate of remission. Other specific leukemias that you may be tested on include hairy cell leukemia. It is a mature B-cell leukemia and occurs predominantly in older men. Predominantly, patients present with pancytopenia or splenomegaly, and these patients are at increased risk for opportunistic infections or inflammatory diseases of the vasculature or vasculitis. Prognosis is good in treatment with purine nucleoside analogs or splenectomy if there is significant splenic involvement. Hairy cell leukemia gets its name by the finger-like or hairy projections from the lymphocyte, and they are seen both in the bone marrow, peripheral blood, and spleen. Try to burn that picture into your head as far as a sort of a solar pattern of what a hairy cell looks like. Another leukemia to consider is adult T-cell leukemia lymphoma, which is caused by a retrovirus, HTLV1, which is similar in morphology to the human immunodeficiency virus as well. It's primarily found in HTLV1 endemic areas, Central Africa, Japan, and the Caribbean. The disease has a very long latency period, and the ATLL is often not manifest until decades after the initial infection with HTLV1. Patients can present with widespread lymph node or peripheral blood involvement, or even involvement of the skin. The prognosis is generally quite poor, but does vary, and often depends on the patient's ability to avoid opportunistic infection.